Dear colleagues, in partnership with Nephrology Dialysis Transplantation, NDT, the official journal of the European Renal Association, MARKUS at Home welcomes Professor Emilie Cornec-Le Gall in Brest, France, and Professor Roman Müller in Cologne, Germany, in order to discuss SGLT-2 inhibition in patients with autosomal dominant polycystic kidney disease, ADPKD, focusing upon the DAPA-PKD and STOP-PKD studies initiated by Professor Cornec-Le Gall, Professor Müller, Professor Dominique Guéret, and others. The study design of DAPA-PKD and STOP-PKD has been published in Nephrology Dialysis Transplantation, NDT, earlier this year in a paper which has been picked by the journal's editor-in-chief, Dr. Anders, and by MARKUS at Home editors as our NDT's paper of the month. Dear Emilie, welcome at our channel for the first time. Dear Roman, welcome back at home.
Yeah, I have the honor to introduce our guests. So first, I would like to start with Emilie Cornec-Le Gall. She is a professor at the University of Brest in France, and Roman-Ulrich Müller is a professor of nephrology at the University of Cologne. Together with Gunnar Heiner, we have today two guests from Vienna, from the clinic Ottakring. One is Sarah Siacek, and the second one is Professor Markus Seemann, the head of department. Gunnar Heine doesn't need to be introduced. He is our host for all the MARKUS at Homes, and we are very delighted to have such a great webinar today on SGLT inhibition and PKD. So we will hand over for the presentation.
The paper for which we had actually teamed up here got the title SGLT2 inhibition for patients with ADPKD, closing the evidence gap, based on the key consideration that also underlies the trial that there is indeed an evidence gap. And here quickly a couple of disclosures, but since this is an IIT and does not come out of industry, nothing interfering with the trials we're going to be discussing today. So that was the paper, and that is a group of authors and a team that was led by Emilie and me. And I'll quickly introduce why we chose those people to contribute here. We mainly invited everybody who has running trials on the question of SGLT2 inhibition or is preparing, and that's mainly us with our team's trials for the future. This is Kiyotaka Uchiyama, who's done a published, by now, wasn't published back then, crossover trial. Michael Conko from Colorado with a study on empagliflozin, Roland Schmidt in Hanover with DAPA-PKD, and then me and Ron Gunsvoort for STOP-PKD, and Dominique and Emilie for the DAPA-PKD trials, and we're going to share more details on those. I think by now, after many years, people are quite familiar with how, in general, this works, so we'll keep it short, right? The sodium glucose co-transporter 2 is inhibited by the available drugs right now. Others inhibit both 1 and 2, but we're talking about 2 mainly. And then the consequence of this inhibition is that hyperfiltration is reduced, albuminuria is reduced, oxygen consuming transport activities are reduced, blood glucose goes down, uric acid, blood pressure and body weight. And in the end, all of this, and it's a multimodal way of preserving kidney function, but leads to kidney protection. Now, that also results in the fact that this is really, in this case, not one single thing we treat that then probably leads to maintaining kidney function in a specific disease, but actually multimodal ways of really reaching not only renal, but also cardiac protection. And that's nicely reflected by the fact that's the first treatment, right, for heart failure with preserved ejection fraction. Now, the key trials that had been run for chronic kidney disease as the endpoint are depicted quickly here again nicely, starting with credence in type 2 diabetic patients, then DAPA-CKD, also without diabetes, but with rather high urine albumin creatinine ratio, and then the latest trial, EMPA-Kidney with empagliflozin, also including patients without a high urine albumin creatinine ratio requirement. And this altogether, as the set of data that we have resulted in the KDIGO CKD guideline recommendations from 2024, recommending to treat adults with an eGFR of above 20 with a urine albumin creatinine ratio above 200 milligram per gram, or heart failure, obviously, is irrespective of level of albuminuria, and patients with an eGFR 20 to 45 also be treated even if there is no significant albuminuria. Now, back to ADPKD, this comes with a problem. ADPKD is a genetic disease. Treatment should be initiated as early as possible, and albuminuria is not necessarily a part of this. So treating so late a disease that's lifelong, and we know in an 18-year-old what will happen later on, is probably not wise. So this is a bit of a problem. And why do we not have this in the guideline? Well, essentially, PKD patients were not recruited by the trials. This is now for DAPA, but essentially we don't have any data for them because this was an exclusion criterion from any of the trials. And that is nicely reflected by now the KDIGO ADPKD guideline published earlier this year, and Emilie was a part of the key author group there, clearly saying in a practice point that SGLT-2 inhibition should not be used to slow eGFR decline in people with ADPKD at this point, but coming with a research recommendation that studies are needed to evaluate the safety, efficacy, and metabolic effects in this setting. So what are the disease-specific considerations for PKD? Why should we think about it, and why should we not use it yet potentially? There's many reasons why we believe it is actually beneficial, right? The blood pressure effects, the weight gain, metabolic effects, even down to the mild degree of ketosis there is probably helpful in ADPKD, also the effect on signal transduction pathways and the effect regarding hypoxia. But essentially, this would mean, right, we would be very interested in this field, but we cannot necessarily tell yet. And there is data showing in both humans and rodent models that SGLT-2 inhibition comes with an increase in vasopressin. And you all know that vasopressin is the key hormone driving cis progression in ADPKD. That's why tolvaptan is a drug targeting the disease. So necessarily we cannot exclude safety concerns that are disease specific. And this is nicely then summarized. Again, I'm not going to go through all of this again in our recent review in this graph, showing that there are many potential beneficial effects, but there may also be potential disease-specific negative effects due to natriuresis and glycosuria, including, we don't know about cyst infections, but including the vasopressin release. Can we extrapolate from preclinical data? Cutting a long story short, we can't because it's heterogeneous. There is no really good disease model for PKD, and the best ones weren't even used in this setting. And there's some positive signals, but there's also negative signals from the preclinical data. So we cannot say anything about the clinic there. What's available as to clinical evidence? When we started this project, November 2024, our systematic literature research was limited to observational data, 2 case series, 2 case reports, collectively providing retrospective data on 29 patients with ADPKD. So it's quite clear we don't know, right, based on these data about a potential TKV increase associated with vasopressin or potential attenuation of eGFR slope. There is one piece of evidence that came out later and is not part of this, and that's why we want to share this. This is a retrospective cohort study within the Veterans Health Administration in the US, 348 patients who started an SGLT-2 inhibitor, patients with ADPKD, and they also did a target trial emulation comparing SGLT-2 inhibitor uses with DPP-4 inhibitor uses. 93% male, median eGFR 53. I'm going to say something about this in a moment as well. The pre-initiation eGFR slope, this was all provided per 90 days, was minus 0.79, so would be extrapolated to a year around this figure here. They are separated the first 3 months from the rest of the year because we have the hemodynamic effect of SGLT-2 inhibition, which we kind of want to try to correct for. Well, in essence, what they found is that if there is anything, there is a positive signal also compared to the DPP-4 inhibition. So it is something that further tells us this is very interesting, but can we say anything about whether this really works for PKD? Necessarily we can't. And the key reason for this, among others, right, but is lying here. this is a very specific patient group, mean age 68 with a median eGFR of 53. So the main cause of kidney function loss in such a cohort is not PKD. This is very slowly progressing PKD, but is other factors, comorbidities and diabetes. So we're treating those comorbidities and not the PKD. So we have to be careful with it. Nonetheless, it's encouraging. And that's where we want to talk about the ongoing or completed studies, back then still all ongoing. And we in the paper provide a table on those, and we separate them by different degrees of evidence they'll provide. The first group here are small studies that look at kidney relevant outcomes, but are essentially a phase 2-like design, I would say, in 30 to 50 patients, a duration of 6 to 18 months. There is a study with a biochemical endpoint, which doesn't focus and only treats for 2 weeks. And there are then the phase 3 design trials, which we're going to talk about in more detail later on. Now, let's quickly start with the ones up there. I already talked about the Japanese trial while we had a colleague from Japan on board. This was a multi-center study, 30 patients on tolvaptan, all of them, and then randomized to a placebo, to dapagliflozin or a control arm as a crossover trial in the end. And just quickly to say this all looked quite promising. So there was a moderation of the eGFR slope, and also the change in TKV probably was rather attenuated. This quickly represents the trial design again. And as you can see here, at least when you look at the cystatin eGFR and the combined creatinine and cystatin eGFR slope, there was a benefit of treating with dapagliflozin in this small study. Now, the second piece there is the study I also talked about before from the US, which mainly focuses on feasibility, Michael Conkol's study with the primary aim to determine the feasibility in terms of safety and tolerability, and dapagliflozin once a day in PKD patients, 50 patients there. They exclude tolvaptan patients, so that's different to the Japanese trial, right? And that's always important to think about, and include mainly rapid progressors. And the third running phase 2 design study is EMPA-PKD, in this case empagliflozin, again in Hanover, Roland Schmidt, 44 patients. They stratify by tolvaptan, so enroll both patients. The treatment duration is longer with 18 months. That makes it interesting. Primary outcome is delta TKV. Delta eGFR is the secondary outcome, and they're still recruiting. There is a paper on the design specifically who's interested there. And with that, let's move over to the trials that are expected to answer the question in the end, right? All of these trials will contribute very important safety information and may even help us later to understand a little bit of the interaction with tolvaptan, but we will need adequately powered trials. The first is the one that I will present, STOP-PKD, which is coordinated from Cologne by me together with Philip Scherer, and co-coordinated on the international side by Ron Gunseford. We have 24, we're actually up to 27 centers in 4 EU countries. The initiation is planned late this year. So this is has recently been submitted to CETIS, and I have a deadline tomorrow. Pain in the neck, but we'll get that through. It's investigator-driven, multi-center, randomized, placebo-controlled, and double-blind, and will treat patients for 3 years with dapagliflozin. And with that, and before comparing those trials designs as well, I would hand over to the DAPA-PKD study as the last piece there.
Thank you, Roman. And I have the easy part now of presenting DAPA-PKD, and at the exact same time then Roman received the great news that STOP-PKD trial was funded. Together with Dominique Guérotte from Rouen in Normandy, we received also the good news that the DAPA-PKD trial was funded, and it will be a multi-center trial in 34 centers in France. So over 90% of the academic French centers and several non-academic centers from the GenKIST cohort who have been involved in clinical research in ADPKD over the last 15 years. And so this study is government funded by the National Plan for Research in Health. Here is the design. So it will be a multi-center randomized placebo-controlled double-blind trial comparing placebo and dapagliflozin over 24 months. And the primary endpoint here is the percentage of change in TKV between baseline and month 24 with dapagliflozin or placebo. TKV will be determined by a centralized automated calculation. Concerning the main objective, it will be a non-inferiority test to determine whether dapagliflozin is non-inferior to placebo, using a margin of 5% as a non-inferiority bound. So why is that? In fact, when we prepared the trial design, our concern was that a superiority trial based on a composite renal or cardiovascular endpoint would require the enrollment of a cohort of over 1,000 participants, and within 2 years, a duration of 2 years. And so that would be difficult in the constraints of an academic trial. And the main clinical question here, based on the existing data from the SGLT-2 study in CKD, and on the conflicting preclinical data that Roman showed you, is to address the issue of renal safety. And so the purpose of our trial is to demonstrate that administrating dapagliflozin to patients with ADPKD does not lead to an excessive variation in TKV, which is the accepted surrogate marker for disease progression that we can use over a period of 2 years. And so with that, we will have, of course, several secondary endpoints. A lot are eGFR related, total slope and chronic slope. We will also look at specific events such as kidney stones, urinary tract infections, and of course, we'll look at quality of life and occurrence of MACE. So DAPA-PKD versus STOP-PKD, there are a lot in common. So the key inclusion criteria are eGFR over 25 ml per minute. The age, so we both include patients over 18 years old. And so we go a little bit later with DAPA-PKD, also hoping to look at the occurrence of MACE in DAPA versus placebo. And we enroll rapid progressor based on Mayo class CDE. In both trial, patients under tolvaptan cannot be included, and this is something we can discuss during the Q&A. It was a difficult decision to make, but we were essentially concerned that there would be more discontinuation in the patients under tolvaptan based due to maybe increased aquaresis. And we can further discuss that during the Q&A. So we decided not to include them in our trials. And the primary endpoint, as you have seen, are slightly different, but we were able to end the duration also 24 months versus 36 months. But we teamed up and were able to harmonize the trial design, the time at data collection to ensure the feasibility of a pooled analysis after completion of the trials. And I think this is really an excellent opportunity to increase power on the overall and to perform relevant subgroup analysis and definitely settled the question on the value of SGLT-2 inhibitor in ADPKD. So with that, thank you all very much. So to Roman, of course, Ron Gansford, Dominique Gerot, and Philippe Scherer. And do not hesitate to reach us if you have any questions. Our emails are included.
Thank you very much to Professor Cornec-Le Gall and Professor Müller both. So these studies that you are making are very interesting and very insightful, and we're all very excited to see the results. My first question is actually about the tolvaptan use that you just mentioned. So Professor Müller already mentioned one Japanese study where they actually had patients on tolvaptan already. Why did you choose to not allow tolvaptan use? Are you expecting some bias, or what was it exactly?
Well, thank you for this important question. So first, the data from the Japanese studies were not available at the time of the preparation of the trial. And we must underline that although interesting, it's still a limited number of patients. There will be further information from the ADPKD trial because some patients are also under tolvaptan and SGLT2. But our concerns were that maybe there would be an increased aquaresis due to increased osmolality. Well, in the limited data that we have now for the Japanese study, it does not seem to be the case, but it was one of the concerns that the subgroup analysis also would be challenging because the number of patients under tolvaptan would be smaller, and that there might be also group disbalance in case there were more treatment discontinuation in patients under tolvaptan. So these were our main concerns, and that's why we decided. And also, if we want to look to the eGFR slope as an important, well, and that you have a part of patients under tolvaptan, stopping tolvaptan, restarting tolvaptan, it would make also the analysis more complicated. But this is an important issue. And
if I may just add this, now imagine the two trials get positive and you will report in, say, 2028, 2029, that you have renal protection in ADPKD with SGLT2 inhibitors. What will you tell us in 3 years? Shall we combine then the two medications, tolvaptan and SGLT2, or shall we then choose either for renal protection? And I'm aware this is highly speculative.
Well, I guess, I mean, we're going to have, so maybe quickly again, we would have loved to answer that question. It was in the first trial designs. Emilie and I decided this entirely, or our teams entirely separately, without discussing actually for the same reason. So we came to the same conclusion, which is reassuring. But and in essence, such trials, investigator-initiated trials, are tied towards power, right? So you have to avoid anything that in the end would allow to address two questions, but answers none of the two. So essentially, this was the risk and a very targeted decision. What will we tell you? I mean, we're going to extrapolate a little bit at least from what we learned from MARKUS plus the Japanese trial. That's as good as it gets. Then we will know that there are no safety issues, hopefully. We will know there's a beneficial effect. There's two different modes of action there involved. And in essence, it'll depend a little bit on the effect size we see as well, right? I mean, that's an important point. If it's really large, it may be very different from a modest effect size. But essentially, it will probably, unless we have different signals from MARKUS now, also allow for a combination and individualized decisions. Another point for PKD will probably be there are more and more trial programs that are starting. So there will be entirely new options. And it's more likely that these new options, if they are powerful and efficacious, that they will be combined with SGLT2 inhibition in the future than with tolvaptan. That's what I would expect at least. So that's probably what will happen, and we will have to live with a certain degree of uncertainty. But I would discuss that individually with patients. And if there is no adverse signals in MPA-PKD as well, and we have rather points saying that probably there is an additive effect, yes, then combination, depending on whether patients are willing to take the impact on everyday life of tolvaptan, is a possibility and will be a possibility. That's at least my take. I don't know, Emilie, if you see that differently.
I totally agree.
Thank you so much for your answer. Maybe another question from me. Will you also be analyzing patients on a ketogenic diet? Because as Professor Müller already said, we do know that there is a mild effect of ketosis in SGLT-2 inhibitors. So is this something that you will also look at in your studies?
Well, I mean, ketogenic diet is probably partly something I have to say something about. No, in essence, I mean, it's not part of the trial, at least but we don't exclude them in our trial. So we will collect that information because some of our patients are in ketogenic diets, but it's clearly not a focus. We will need the ketogenic diet trial, still struggling for funding there, to be honest. Appears to be more difficult than a pharma, a drug trial, but still fighting for that, but that's a separate question. But I think what we can do, I mean, what Ron Gansevoort already did is in their cohort, the DPAC cohort, to correlate the baseline BHB levels with outcome in the future. And I think we can correlate the impact of SGLT2 inhibition on BHB formation ketogenesis and see whether that correlates with the impact on outcome. I think that'll be very interesting and may help us down the road to again convince people that we have to continue getting the evidence for ketogenic interventions as well.
I would love to add one question with regard to co-medication. So there are a couple of trials now running with thiazides in ADPKD, and one might speculate that if there's some diuretic effect of SGLT2 inhibitors in the long run, and I'm aware that some people say, particularly Professor Tietze, this is no long-term effect, but let there be a immediate or long-term effect on diuresis. So one might speculate that people randomized to the SGLT2 inhibitors might receive less thiazides and might theoretically then not receive the benefits of thiazides, if any. So will you record intake of other diuretics? I guess you will want to.
Yes, we will record the use of diuretics and antihypertensive medications. Patients have to be within BP target, and they can use any BP medication. Well, there is no contraindicated BP medications.
And I think, I mean, in my experience, the subgroup on thiazides will be a minor subgroup. So I don't think that the selection of patients for thiazides during the trial, influenced by which arm patients are in, will have a major impact on the outcome. Recording it will be very important nonetheless. And so far, I mean, the potential beneficial effect, right, that is examined in HydroProtect is mainly with the combination of tolvaptan again for thiazides. So we don't really have indications for thiazides on their own. So I think it'll be important to record that. But also considering that we have a lot of young patients and so on, the group is going to be rather small, most likely.
So maybe two questions and 1 point from my side regarding the DAPA-PKD study. So you are looking at the total kidney volume, and a very basic question, why, in brackets on Earth, should SGLT2 inhibitors reduce the kidney volume or retard or block or impair the cystic growth?
Right. So what we are looking at the TKV is whether it is safe to prescribe SGLT2 inhibitors to ADPKD patients, because the concern was that there would be a TKV increase because SGLT2 inhibitors increase peptide level because of the conflicting data in animal models. And so we chose TKV as an endpoint to show that hopefully there is no TKV increase in DAPA-PKD, in DAPA treated patients compared to placebo.
Okay, I understand, because you talked about the hard possibility of a superiority trial, but here you want to see that there's at least
in the secondary endpoints, we'll look at kidney function related and at the chronic slope, etc.
Okay.
But I still want to say there could be kidney reduction, right? I mean, there are some pathophysiological moments that that you could consider, and that is, for example, the ketosis that people reach, which could have an impact, and there is also the impact on hypoxia and energy consumption, so that could also have an impact. We'd not expect much, probably, but there is at least a rationale to say it could also be beneficial despite the vasopressin increase. And just quickly about the vasopressin increase, this is minor, right? Compared to anything, even though we have to rule out safety concerns there. But if you compare that to the increase you see on tolvaptan, for example, where you get a full-blown response, it's a totally different thing. And in some of the animal models may also depend on hypovolemia that was developed due to high doses of SGLT-2 inhibition and too little fluid intake.
Yeah, but regarding ketosis, because you include also advanced CKD, PKD patients, because we looked at that, in combination with diet and together with SGLT2, so there is no more BOHB production when the GFR, as we saw it, is below 45, 50 milliliters per minute. So it vanishes because the glucose output is drastically reduced. So I wouldn't expect in this case that there's any mediation of a supposed SGLT2 inhibitor-mediated ketosis, whatever the effect would be. Just as a matter of fact, that what we saw in the observations.
No, absolutely. But that would leave in the trial still, around 50% of the participants in whom you can do this analysis and potentially see an effect. And I mean, that's all things we'll have to take into account. And interestingly enough, for those 50% for which there may be more of an impact on that side, kidney volume may be a very important endpoint, because those are the ones that lose little kidney function during the trial duration, because they're young and have a maintained kidney function potentially. But it'll be, I mean, there's so much you can do there. Actually, we all do a lot of biosampling as well. So down the road, any questions we have mechanistically will be very interesting to look at.
And third, I'm, at least from my experience, the ADPKD patients are, well educated, well informed, a lot in social media, know a lot, if they're not in a denial state, so to say. And now, 2025, when a patient sees you, should I tell them simply, wait 3, 4, 5 years? I always tell them, hey, there are the ketosis studies and maybe other research tools, now the SGLT2s. Or would you go so far as to say, let's start it, apart from waiting for the evidence? Because 3, 4, 5 years is a long time.
I think there are many clinical trials ongoing. And at the moment, I would go, and what I do is I go by the standard of care and tolvaptan and or clinical trials, depending on based on the discussion with the patient. And I would not introduce SGLT2 inhibitors for nephroprotection in an ADPKD patients before having more evidence. There are some specific situations, patients with heart failure, or in the guidelines we say that SGLT2 inhibitors in type 2 diabetes patients and ADPKD were not recommended, but I think this is maybe more a bit questionable. But apart from these two situations, I would wait.
We would currently follow the guideline there on that point. And also because I think it is right. I mean, it is a difficult question in an individualized setting. Sometimes you may have to come to other, as always in medicine, right? But in essence, if you consider that, which is a very good thing, that there's more and more opportunities for CKD that are upcoming as well, and finerenone is among that, and aldosterone synthase inhibitors and so on. The problem is all of them are not unlikely to also have an impact in PKD. But the problem, on the other hand, is if we always extrapolate and say this is very likely and good to happen, we also have to consider that that we have been taught differently by trials in the past, and then we will at some point, if we do this, put our patients on 3, 4, 5 drugs for which there is only extrapolated evidence, and that's why I would really aim to the key aim has to be we create that evidence and also avoid when there are new upcoming opportunities that suddenly everybody is on drug without evidence and we can't get the evidence anymore. It's our responsibility as a field to get this evidence. With the limitations we have, that funders are difficult to find, but that's also why we're so glad that we have the opportunity there and that the combination of the two trials really secures power. We're both powered for what we're asking, but the problem there is it is always tight, much tighter than in pharma trials. With the combination, we will answer the question, and it is a couple of years, but I would for now wait.
But I think in your case, Roman, you would send the patient that asks you maybe to a nutritionist.
Definitely. I mean, or would talk to him myself because there's a limitation in nutritionist availability as well. But these are all things that are definitely part of the package. And again, also on that side, we need much more evidence for all of the angles that cannot be funded by industry.
So I think both of you mentioned it already, but I think it's very important, especially when you showed DAPA-PKD and the exclusion criteria. We have the same issues, all the exclusion criteria usually name AAV, lupus nephritis, and PKD, and I don't really get that. And this continues to happen, and even, companies who have not formulated that before are now starting to adopt that. But how can we as a community actually change that in the future? Like for genes and kidney and for immunonephropathy working group, if we would stick together, can we really make a difference and ask these companies why they still have this?
I totally agree, and I think it's an excellent point. And probably in the coming years, we have to be extra careful not to reproduce these situations and to advocate as a group might be helpful.
But you also have to be aware, right, that we then have to make sure that the subgroups are large enough to answer any question on those. Because if industry then just claims there were 10 ADPKD patients, so we've answered the question, just extended to those is a problem too. I think this is a political question, right? I mean, all companies say they want to be inclusive and include all of the rare indications, and that would normally come with a requirement once you have the broad indication to also get the data for the rare indications as an effort in the field. This is something that's not solved yet, and where we will need policymakers as well. Another thing that I think as nephrology we will have to invest into is innovative trial design. So we will have to think about this more, and we will have to learn from oncology and infectiology and run adaptive platform trials that allow for repurposing in rare indications. And there will be so many new upcoming drugs that it won't be possible for us anymore to study all of them in a sequential manner in individual trials. So I think that that's really wise, and there we have to team up, right? This is nothing that one group can solve on its own, and will also be a topic for the society level, and ERA will think about this. And I think if it is AAV or if it's ADPKD, it doesn't matter. We have the same problem there.
Absolutely. I think we need to team up and also come up with, some lists for the policymakers where we really try to convince them. We have the same issues right now with designation for rare disease with lupus and lupus nephritis, where they won't accept lupus nephritis, for instance, as a rare disease anymore in the European Union, which is kind of weird. But anyway, this is a different story. I wanted to come back, Roman, you mentioned it about CT's application. So I also want to hear a bit about, the hurdles and the struggles you guys had with setting up these trials, because we just see, the greatness of a clinical trial running, but what were the biggest hurdles actually on the way so far?
And the biggest hurdles in my views, I mean, we're starting with funding. This is a bit specific for our situation. It took us 3 years to go to the review process. That's normally when research is not relevant anymore, right? So, and everybody is put on drug already by the time you get the funding. This is something that completely has to be changed. It's also my feedback, as much as I'm really grateful to the German Research Foundation to fund this, but this was a huge problem, and even resulted in the fact that I was asked at some point I should update my proposal because it's outdated, and I was like, well, it's outdated because it's been sitting there forever. But that's solved. The other thing is that in my experience, the expertise that is there on all levels with publicly funded IITs is limited. That includes universities. This includes the finance departments of universities. How do you deal with the invoices with other universities, overhead, etc., pp. And the funder doesn't know either. So these are things, a large learning process, and takes years of back and forth and a lot of uncertainty. Also, universities on the level of the faculty have to learn more about this. And there are efforts here in Cologne, for example, to get to a new level there in the future. And then another major point we saw is trial drug. The entire production of trial drugs and placebo has been outsourced to industry. And there is a very limited number of pharmacies in Germany at all that are still able to produce formally trial drug, but that doesn't mean they can produce the drug for such a trial. They can't. Even storage space for drugs is too low. And this has been a very long process. Industry is not willing to contribute to trial drug. And even if you pay for it, they're not willing to give you drug and placebo. I can just clearly say it as it is, right? I mean, we have very friendly contacts, and I really like working with industry, but that was impossible with all players on board. And that's a problem because they have a monopoly on this production to a certain degree. So this is also, again, for policymakers, at least this should be made possible down the road. Results in facts. That's also for the Alport trial that's running right now, that then you put a lot of your research funding into buying the trial drug. You don't even get the placebo, so you have to put it into capsules potentially and so on. Huge capsules that even children have to swallow, then unblinding risks that come with this, and so on, and also expiry dates that are much earlier because the capsule, and so many problems that you just don't want to have in a clinical trial. We've solved that. And we're currently looking into trying to help other people there as well. But it's been a long run, and I'm still looking forward to the input that industry will have and the criticism, and trying to discuss this. And we're having these discussions that people are not necessarily just only glad about new solutions in that field, but that needs discussion.
Is that more easy in France, Emilie? Because we see more and more clinical studies coming from France in the last years.
So in terms of funding, we were very lucky to be funded on the first attempt. So it's a 1-year process between submission of the letter of intent and final decision after submission. So this was excellent news. In terms of, I have exactly the same comment than Roman, and we discussed extensively together about that, about medication price and access to placebo and access to the drug. It's 1/3 of our total budget, just the medication part, which is huge when you consider that it's a trial with also 2 MRIs, 34 centers, etc. So yes, it's a very, and so not having any kind of support to access the drug at or the placebo is really a difficult point, and something that I think industry could support a little bit more.
But we can also learn, right? And we will have, and we're considering this too, that, we can potentially also come up with guidance papers to help in the future and to discuss that better in the field and not have everybody reinvent the wheel, because we ran into so many obstacles that if you know them, you can avoid them. And also CETIS, we have to learn together as IIT PIs, right? I mean, we haven't talked about that yet. CETIS is good to have. We need harmonization and a central contact for this. But then still there is no harmonization. So every country, I mean, that's specific for our trial with 4 countries, still has different requirements, different forms for the same thing, minor differences. But I put people on that for weeks to find out, right? And this is a problem. And we now have the first RFIs out of CETIS, deadline tomorrow, as I said. And this is really just shows us that Austria, for example, wants a co-PI. No other country still wants a co-PI to be even submitted and named and so on. And then you start, every time from scratch. And Austria is just an example. Spain has other things. In Spain, you have to define the ethics committee while you cannot choose in other countries. So you kind of you learn that while doing. And there, on the one hand, guidance and potential guidance paper society back would be good. But on the other hand, it really needs more harmonization because none of these things are relevant to, GCP. And we should consider those things important that are relevant to our patients and to the trial data, safety, etc. And that's GCP essentially. And the rest has to be harmonized and abolished.
Plus 3 different languages. One more question from me. You are collecting information on cyst infections, surely, but do you expect an increase in cystic infections?
No, essentially not, right? But you still have to address this point because there's a major concern in the field. And still, I mean, there is this really, really little signal on urinary tract infection. I mean, there's a whole signal on general infection. There is still a very small signal on urinary tract infection as well that we believe is not really clinically relevant down the road. But since this is so much in the community, it has to be a part of the discussion and something we need to prove, especially in a situation in which those severe infections like in PKD do play a major clinical role as a complication.
Well, I think coming back to the trial design and issues, I think we really need to put this together, to help others for guidance, because I'm also going through the same issues as you just described. It's a nightmare. And I think if you're not resilient, you would give up doing that in the future. And I think this is not really good for us if we are getting frustrated just because we need to do a lot of add-on work, which is basically not our daily practice. But we need to learn how to navigate that in an easier way, I would say.
All the more, thanks so much for initiating these trials. Thanks also for joining us tonight. But surely it's really a tremendous amount of work to initiate this and really to bring this through the different institutions. So we are eager to follow the trial design and the trial rollout. We saw the centers that take part in France. For those in Germany, Austria, and Spain, I guess there will be a list of participating institutions for our colleagues from these countries who like to see who does participate. And we plan to see the 2 of you back quite soon for a quite different topic, namely you have published another very important paper in NDT on a potential new nomenclature for chronic kidney disease. So until then, thanks so much. Have a nice evening. Thank you.
Thank you.